Over the course of my 2-week neurosurgery rotation at the hospital of the University of Pennsylvania, I witnessed surgeons access the brain to treat various brain pathologies in many ways. In many cases, a large craniotomy or removal of a bone flap was required to access the brain. The most minimally invasive case I watched was the resection of a pituitary tumor using a transsphenoidal approach by Dr. Daniel Yosher. In this case, a very small piece of the skull, called the sella turcica, was removed to access the tumor. But what if I told you it was possible to see the brain directly without resecting any skull at all? William Shakespeare famously said that the eyes are the window to your soul. While beautifully poetic and philosophically interesting, this is not super relevant to neurosurgery. I bring up Shakespeare's quote because with one small amendment, substituting soul for brain, this quote becomes very relevant for neurosurgery. The eyes are the window to your brain. My name is Christopher Aiello, and I am a second-year medical student at the University of Pennsylvania. This is my capstone presentation for my neurosurgery clinical rotation titled The Window to the Brain, Assessing Pituitary Tumor-Induced Optic Nerve Damage Using Optical Coherence Tomography and the Future of Visual Recovery. I have no disclosures to declare. Non-secreting pituitary tumors often present with the chief complaint of vision loss. Unlike secreting tumors, which cause hormonal abnormalities that lead patients to present earlier, non-secreting pituitary tumors enlarge silently until they grow so large that they physically compress the overlying optic chiasm. This chronic compression causes atrophy of the crossing fibers of the optic nerve, leading to a specific visual field deficit known as bitemporal hemianopsia. This pattern of visual field loss can go unnoticed at first, as patients only lose peripheral vision, leading to a more tightly framed view of the world, as shown in this image on the bottom left. The standard of care for assessing vision loss in patients with non-secreting pituitary tumors is visual field testing. Visual field testing is a test of functional vision where patients indicate if they can see various flashes of light in their peripheral vision. After the test, a map of the patient's functional vision is generated, with darker tones indicating areas of vision loss. Visual field testing is an imperfect assessment and may not tell the full story of what a patient should expect in terms of visual recovery after the resection of a pituitary tumor. Optical coherence tomography, or OCT, is an imaging modality used to directly measure the retinal nerve fiber layer with high resolution. The retinal nerve fiber layer, or RNFL, is an indicator of the structural health of the optic nerve. Because the optic nerve is a part of the central nervous system, if axons are destroyed, regeneration cannot occur. RNFL thinning has been thought of as an indicator of axonal death and therefore irreversible vision loss. Studies like this paper have shown that preoperative OCT measurements of RNFL thickness are a much more accurate predictor of visual field outcomes in the immediate postoperative period than functional visual field testing alone. OCT therefore allows neurosurgeons to provide much more realistic expectations for postoperative visual recovery in patients with pituitary tumors. When thinking about return of visual function, it is important to consider that visual recovery typically follows 3 distinct phases, each driven by different neural mechanisms. First, the fast phase, which occurs within minutes up to 1 week post-op, reflects the effect of removal of physiologic conduction block caused by the tumor. Second, the initial slow phase, which occurs on the order of weeks and up to 4 months post-resection, represents the remyelination in optic tracts and restoration of exoplasmic flow. Finally comes the late slow phase. This is the visual recovery that occurs months to up to 3 years post-op, and it is hypothesized to represent anterior visual pathway modeling and cortical plasticity. This is where things get very interesting. Recent studies have shown that preoperative OCT may not be telling the whole story in terms of a patient's potential for visual recovery. While it was once thought that RNFL thinning represented irreversible vision loss, this paper showed that while patients with RNFL thinning had worse visual outcomes in the immediate post-op period, over the course of 2 years, they continued to recover functional vision. So how can vision be recovered despite axonal loss? Answering this question comes down to understanding that visual function reflects not only axon integrity and conduction, but also synaptic transmission, cortical processing, and network adaptation. Again, this harps back to the idea of the late slow phase of visual recovery, governed by cortical neuroplasticity. Studies like this one, looking at visual recovery after optic neuritis, show over the course of 12 months of follow-up, patients with structural optic nerve damage develop altered activation in the extrastriate cortex. fMRI studies have consistently showed that in patients with structural damage to the optic nerve, there are changes occurring at the level of the brain. The visual pathway starts with reception of visual information at the retina, and then this information is passed down the chain to the optic nerve, the optic chiasm, the LGN, the visual cortex, and finally the association cortex. Compensatory plasticity is the idea that when the quality of input at the beginning of this chain is decreased, the higher order visual network in the brain can reorganize to make better use of the degraded input. This idea is the basis for the idea of the late slow phase of functional visual recovery seen in patients with optic nerve damage. When the way information is passed along the visual pathway is appreciated, the future of visual recovery becomes very exciting. There is work being done to develop intracortical visual prosthetic devices that stimulate the visual cortex using electrodes, giving hope for visual recovery in blind patients whose eyes cannot process visual information in any capacity. A study published in 2020 by Dr. Beauchamp and Dr. Yosher, who are now members of the Department of Neurosurgery here at Penn, showed that stimulation in specific areas produced form vision in blind humans, allowing them to trace various letters that they perceived visually. These findings give hope to the idea that functional visual recovery is possible at the level of the brain, regardless of retinal or optic nerve health. Before ending, I want to specifically acknowledge Dr. Brem for the great teaching and mentorship he provided throughout the course of my rotation. I would also like to acknowledge Dr. Susanna Howard, who is a chief neurosurgery resident at Penn and provided great guidance both on morning rounds and in the operating room every day of my rotation. Thank you for listening.